Hello and welcome to my video on clinical skills for occupational therapists working with justice-involved individuals. My name is Alexandra Ochdorf, and I'm a current doctorate student working with life after incarceration, transition, and reentry, also known as LATER. And I'm a student at Washington University in St. Louis in their program in occupational therapy. So this video is going to cover all the clinical skills in the evidence, as well as things that I've just kind of picked up on working with this population throughout my capstone. So first I wanted to talk about criminogenic needs and what exactly those are, how can we use them to our advantage in occupational therapy. So criminogenic needs really are the factors that lead to somebody's increased risk for reoffending. So those include attitudes, values, and beliefs, which is looking at risky thinking, peer association, so who is in their social circle, their personality, which is looking at self-management skills, coping skills, and more cognitive, higher level cognitive skills, their leisure. So what pursuits are they, or what leisure pursuits are they involved in? Education, employment, substance use, and family factors, as well as is there pro-social communication going on within the family, a positive family environment. So within the domain of occupational therapy, we actually cover all of these criminogenic needs. So that is completely within our scope and within our realm. So we think about a person's beliefs, their spirituality, in order to be client-centered and in order to target our interventions towards them. We think about social skills and social participation. We look at a person's process skills, so their cognitive thinking. We engage our clients in leisure activities, as well as helping them with education and employment issues. We look at substance use as we look at habits and routines. And then family factors, also looking at social participation and how that relates to family. So this is definitely within our scope and within our domain as occupational therapists. So I wanted to talk about OT theory and models of practice. Of course, we want to be evidence-based. So first of all, I wanted to talk about the Person Environment Occupational Performance Model, or the PEOP model. This model looks at person factors, environment factors, what context they're in, as well as their typical occupational performance, and how all of those things combine in order to determine a person's quality of life. And then we also look at the model of human occupation, quite often also known as MOHO. And the reason that this one is really beneficial in particular is because of this emphasis on internal factors of volition, habituation, and performance. Specifically with habituation, a lot of our clients will have substance use disorders or various habits and routines that are pretty ingrained, so that they have goals to change. And this helps us to kind of have a framework to go by in order to help our clients with that. So what exactly does the OT process look like with this population? So luckily, within occupational therapy, the OT process always remains the same. It is always consistent across practice settings. So you're still receiving a referral to evaluate somebody, and through collaboration, creating some goals that then will inform your intervention process. Now, with this population and with every population, but particularly with this population, you want to remain client-centered and really give that collaboration and emphasis in order to provide enough opportunities, ample opportunities for the client to choose what they want to do, to make the client feel heard and seen and give them some choice and agency in the situation. And also something I wanted to emphasize with the OT process is it's important to think about what a realistic long-term goal would be, and think about what options you have and what you're limited to in the correctional facility in order to set your client up for success. So if the correctional facility that you're working in has no ability for you to work on medication management or have your clients engage in some sort of time management skill or something like that, you want to be setting a realistic long-term goal. So maybe that's something you talk about in reentry, or you find creative ways to address those skills and those goals. But you don't want to be writing a goal that a client just can't meet simply because of the context that they're in. So some of the evaluation tools that we use, this is partly from the evidence, partly just things that I've gathered from our assessment battery at LATER. So some self-report questionnaires and surveys, the promise measures are great. There are so many of them, and they cover so many different topics, including self-efficacy, sleep, social participation, depression, anxiety, you name it, they probably have a promise measure for it. We also use the ACEs questionnaire, which is looking at adverse childhood experiences. It's a 10-question form in which a person would answer yes or no to having experienced any of the questions. And it's important for us to ask those questions in order to prevent re-traumatization, but also to get a little bit more of an understanding of what their background may be, and in order to more effectively provide trauma-informed care. And then finally, the sensory profile is really cool, and we don't use it at later, but I think it is a really cool idea to use it, because we do have some clients who have actually talked about how they feel like they're not getting enough exercise in, and feel like really antsy all the time. Maybe they're anxious and are pacing a lot. And those clients may have a really high threshold for proprioceptive input and simply can't get that energy out, get that sensory input in that they need. So that I think is actually a really great idea to think about. Then looking at some narrative assessments, the occupational performance history interview helps to have the client give you a really broad understanding of their life experiences. And then the Canadian occupational performance measure is great because it breaks different occupations into different sections and can help the client to think about what goal areas they want to work on if they haven't really thought about it yet or don't know for sure what they want to work on. And then functional assessments, these are all pretty cognitive based, and that's because this population does have such a high prevalence of cognitive disability or cognitive dysfunction. So this is looking at the executive function performance test, the Allen cognitive level screen, and the Coleman evaluation of living skills. Some common goal areas, this is by no means an exhaustive list, but these are pretty common. These include time management, social relationships, goal setting, coping skills, sleep hygiene, employment skills, leisure, financial management or budgeting, health maintenance, and addiction management. So I wanted to talk about just a few of these. Number one being time management. That one may seem a little bit odd, but for some of our clients who are coming from being incarcerated or having been in a correctional facility to then coming into the community, oftentimes that's such a difficult transition because you're going from such a highly structured environment to really no structure at all. So managing time is a really big area of a really big goal area for a lot of our clients. So breaking things down and giving them some strategies for time management is usually really effective. And then kind of along those same lines with goal setting, a lot of our clients also leave a jail or a prison and correctional facility and have a lot of goals that they want to accomplish. And sometimes they can get discouraged because these goals are really lofty, like starting a business or going back to school and getting a degree. So they're really big long-term goals that are great and are excellent ideas to keep in mind. But sometimes they're so big that it feels difficult to know where to begin and how to actually get started with it. So that's something we help our clients with a lot, is to set a realistic goal and figure out, okay, you want to start this business, but what do we need to do first? Like what are the different processes that we have to go through first in order to get to this long-term goal that maybe is still a few years away? And that also, by breaking things down and setting realistic goals, helps to build self-efficacy and confidence that, you know, I can achieve this if I just take things step by step. The last one I wanted to talk about that may seem a little bit odd is leisure. So a lot of our clients, like I was just saying, they come out of having been incarcerated and have so many goals and so many things that they want to accomplish, and they just simply feel like leisure is not a priority whatsoever. But from an occupationally balanced life, we know that it's important to engage in leisure in order for us to have a balance of self-care. So sometimes it takes a little bit of motivational interviewing or understanding what the client really wants in order to get them to see that leisure may be beneficial. So the stages of change, the trans-theoretical model, is something that we use super often, and a person can enter this cycle at any point, and they can also regress. So kind of starting from the beginning, it begins with pre-contemplation, which is when someone says, I have no problem, I have no need to change, this is not something that's on my radar at all. To then moving into contemplation, which is when they're saying, maybe this is something I want to change, I'm just not ready yet. To then moving into preparation, where they're ready to make the change and trying to figure out what exactly they have to do in order to make that change. Then you're moving into action, which is when someone is actively modifying a behavior, and they're really in the middle of changing that. And in that action phase, they're really actively working. So it's not something that's natural. Once it's kind of natural is when you're in that maintenance phase where you're just, frequently checking in, just making sure things are okay, but it's more second nature at that point. And then the final stage is relapse. And depending on who you ask, some people argue that relapse is not a stage because technically you don't really have to go through it. But at Later, we like to argue that relapse is normal and relapse is really common. And so it shouldn't be something that is stigmatized or that somebody should be ashamed about, because it really is an opportunity to learn and grow and figure out, well, why did this happen? What kind of got in the way of maintaining this behavior change, and how can we improve for the next time? So how exactly do you get through these stages? The main thing that we use is motivational interviewing, specifically using open-ended questions, affirmation, reflective listening, and summary reflections in order to make sure that you kind of got the full understanding of what somebody is thinking. We often use pro-con lists so that somebody can see what the pro and con would be of making a behavior change and gauging confidence in making that behavior change. So gauging what their confidence level is, as well as action planning. So that's getting into that goal setting. Next, I wanted to talk about guided discovery. So guided discovery is really from a co-op approach, which is based in cognitive behavioral therapy, or CBT. The co-op approach is evidence-based to use with adults with cognitive impairments. And the whole guided discovery approach is really asking rather than teaching. So it allows a client to problem solve on their own rather than you just kind of telling them what it is that they should do, which also increases their buy-in and likelihood to engage in that change or in that strategy that they thought of, because they're the ones that thought of it. So that's just a really effective way to engage with your clients, in particular, if you're trying to get them to problem solve something. Now, trauma-informed care, I kind of talked about this before, but trauma-informed care essentially assumes that an individual is likely to have a history of trauma and actively seeks to prevent re-traumatization. So the 5 principles of trauma-informed care include safety, choice, collaboration, trustworthiness, and empowerment. And different ways that we can kind of address these things is, one, through client-centered practice, always being client-centered and making sure that the client themselves is guiding the conversation and feels that there is a level of trustworthiness between the client and the therapist. That being said, you really want to make sure you're being transparent about mandated reporting. Particularly with this setting, you may be mandated to report if they have violated any of their parole or probation guidelines, if they are doing something that's not allowed within a correction facility, things like that. So it's important that the client knows going in what they can and what they cannot share with you. And if they decide themselves that they want to share something that they know will have to be reported, at least they have that knowledge going in. And I talked about this before, but giving positive reinforcement and the just right challenge is really important for building confidence and building self-efficacy. So that's kind of going along the lines of that goal setting idea. You want to provide a fail-safe environment where somebody is achieving goals, meeting goals, and seeing their progress in order to feel motivated to continue going and know that they are making progress and that there is a positive road ahead. So a little bit about re-traumatization. It really is typically unintentional. Of course, it can be more overt or less obvious. So more overt would be like using restraints. That's something that's done pretty commonly. But something that would be less obvious is like a scent, for example, that may be triggering to an individual. something that we try to do to prevent re-traumatization is really emphasize choice. So in any way that we can give a client a choice, we try to do so. So things that we'll often do is ask them what they think their homework should be. So what is it that they want to work on throughout the week? We'll also ask them, if we're wrapping up a goal area, we'll ask, what do you want to work on next? What's like your big priority for our next goal? Something really small that we do, especially when we're working through telehealth, is we'll ask somebody to choose their favorite color to fill out different worksheets, which is just a very small thing, but it seems to go a long way. Next is chart reviewing in detail. So particularly with occupational therapy, where you're having students come in, those students can sometimes cycle through pretty often, and that client might be seeing more than one student. And it's important that the client knows that they're not going to have to retell their story over and over and over again, because it's in the chart. So the students do have to chart review in detail, and it's up to the client to decide if they want to tell their story again, that they know it's up to them, but they don't have to, because that information is available to the student. That's just a really effective thing for preventing re-traumatization, especially for preventing a client from feeling like they don't want to open up to another student, or are having difficulty with the transition of going from one student to another. Using summary statements to ensure accuracy is also really important. A lot of times this population may feel like nobody is listening to them. And even when they are trying to communicate their story, they feel like maybe it's not completely clicking to the other person. So kind of giving a little bit of a summary of what you heard, and actually asking for whether or not you heard it correctly is important for re-traumatization. So that person feels like, okay, they're actually asking me for confirmation of whether or not they're correct in their understanding of what I said. So it opens up the door for them to say, that actually isn't what I meant. That's not what I said, and gives them the opportunity to tell it again. And just gives them that agency back in order to know that they are being heard and they are being listened to, and that this occupational therapy session is for them. And then finally, of course, using guided discovery, just letting the client kind of buy into whatever strategies that they want to buy into, let them problem solve on their own, obviously with guidance from you, but that also helps to build that self-efficacy and feeling that they can accomplish these things on their own, but that they have support in order to do so. Now, discharge in this setting is a little bit difficult to describe, I guess, because it really depends on where you're at. It depends on your structure and your context. Unfortunately, discharge planning isn't really something that's super common with this setting, because it's such a transient nature. So from one day to the next, your client may be gone, and you maybe never set up a full transition plan. Maybe you never got to complete a discharge evaluation. However, if you are given any sort of indication that somebody is going to be leaving, that's your moment to think about transition and think about, well, what needs are not met yet? What do you need in community? What about your medications? Can we continue to talk to you? Setting up all of those things for transition, so that you do have some of the information that you'll need. If you have more time, then you can really plan a whole discharge plan, thinking about progress on goals, thinking about what community resources may be available to them that you can share with them, and then completing the discharge evaluation, including the full assessment battery of what you completed at the initial evaluation to determine any progress. And as I said, this system really is not set up for transition to reentry in the community, and that's where we're coming in. That's why this is such a revolutionary idea. And where occupational therapy really can shine and can be strong in supporting these individuals. Now, for my capstone, some of the deliverables that I completed, one was creating some case studies for students. So there are case studies that go through an initial evaluation, intervention, and discharge to allow students to kind of problem solve in more of a fail-safe way, what they would do in a certain situation with a certain client that maybe the situation isn't going exactly how they're expecting it to, but allows them to problem solve instead of experiencing that with the client. Then I also completed documentation of each session that I led in order to determine progress and goals, and created a chart with each of my clients' goals to see what the status of it was, when had that goal been addressed, and what sort of interventions did I use in order to address them. And then I developed an intake form for the process of transition in order to make it a little bit easier, especially for students who maybe are having a client who's transitioning, and on the fly, they kind of have to think about what questions they want to ask that client before they potentially leave, before they can fully complete a whole discharge plan and transition plan. So these are some of my references about the things that I spoke about earlier. And I just wanted to say thank you so much for listening. And if you have any questions or comments, you can leave them down below. Thank you so much.